Welcome to the debate. Today, we're diving into a really critical divergence in medical practice: how we assess patient risk when facing severe hypoglycemia, and specifically, the danger of hypoglycemia unawareness. I mean, this is the single greatest immediate threat in diabetes management.
And the fascinating aspect, of course, is that the exact same physiological event, a potentially devastating drop in blood sugar that requires external help, is judged by two entirely separate risk frameworks. You've got the individualized, patient-centric model on one side, and then the population-level public safety model on the other.
Exactly. So, our central question, and this comes directly from the material, is this: does the Department of Transportation's framework, which is, rooted in this explicit prioritization of public safety through really strict, often disqualifying functional standards, does that provide a superior and necessary safety architecture?
Or is the nuanced, individualized patient safety and risk benefit calculation that's used in clinical settings, like an urgent care, is that a more comprehensive model for truly managing the complexity of diabetes-related risk?
My position is that for these high consequence environments, the DOT's stringent functional safety standards are, well, they're absolutely essential. The unique liability and regulatory mandate that's inherent in commercial licensing just demands this level of rigidity to mitigate a public catastrophe.
And I maintain that while, yes, we absolutely must ensure public safety, the individualized risk assessment model used in the clinical setting, which, it looks deeper at the mechanism, comorbidities, and recurrence potential, is fundamentally a more complete and sophisticated framework for evaluating true stability. I'd argue the clinical framework is superior precisely because its immediate goal isn't disqualification. It's comprehensive diagnosis and safe disposition. It mandates a highly granular, individualized assessment focused first on the immediate risk of recurrence and, crucially, the underlying cause. I mean, these are the non-negotiable elements for a safe discharge plan. Think about the urgent care clinician facing a patient who's just been stabilized after a severe low. They're running a really complex decision tree in their head. Okay, immediate stabilization, check. Confirming severity, did they need help from others, which indicates a functional failure of counter-regulation, check. And then evaluating their current status. But then comes the deep dive. Was the cause clear and reversible, a one-time dosing miscalculation, unusual exercise, a missed meal? Or is this something more intrinsic, an unresolved instability rooted in a change in kidney function or an insulin regimen that is just simply too aggressive? So the clinician has to weigh the benefits of sending that patient to the ER, higher monitoring, sure, immediate access to endocrinology, better documentation, and, let's be honest, reduced institutional liability. They have to weigh that against the very real risks of resource overutilization, the immense time burden, and the financial cost to the patient. This balancing act forces the assessment to be incredibly granular. It makes you look at comorbidities like renal disease or cardiac instability, which, significantly compound the risk of another low. That depth is what's missing in a simple pass or fail functional test.
That's a compelling description of managing an individual's health. It really is. But the moment we shift the context to operating a commercial motor vehicle, the priorities just pivot entirely. When the risk involves a driver suddenly incapacitated at 65 miles an hour, managing that individual's health optimization, it becomes secondary to preventing a multi-ton disaster. The DOT framework, managed through the FMCSA and codified in regulations like 49 CFR Section 391.46, is therefore necessarily rigid. It has to be. Hypoglycemia unawareness isn't just treated as a medical problem, but as a major functional safety red flag. And it's generally disqualifying because the loss of those warning symptoms, well, it compromises the driver's ability to take corrective action. Even a single documented episode of severe hypoglycemia, meaning an episode that required assistance from another person, is automatically viewed as a profound functional concern. The driver is instantly rendered functionally prohibited from operating a CMV until months of documented stability can be shown. The standard here prioritizes functional predictability above everything else. Let's focus on that distinction between the severity and the functional outcome, because this is where the policy mandate becomes crystal clear. In the DOT world, hypoglycemia unawareness is a near automatic disqualifier for operating a CMV. The regulatory cutoff is the fact that the driver required assistance, suffered a loss of consciousness, or had a seizure. That means the body's own mechanisms just completely failed. For the FMCSA examiner, the goal is not long-term chronic disease management. It is the immediate prevention of sudden incapacitation. If that severe episode occurred, the driver is marked as not medically qualified. They need definitive documentation of stability, often involving 3 to 6 months of data, sometimes including continuous glucose monitoring reports, before they can even be considered for recertification. This level of mandated stability is just proof that the system is designed to tolerate zero margin for error.
That's an understandable argument built entirely around minimizing public risk. I get it. But it reveals a critical shortcoming. It fails to distinguish between intrinsic physiological instability and, well, an extrinsic error. The clinical view of severity is far more nuanced. While yes, severe hypoglycemia necessitates an immediate and often aggressive response, needing help is a massive clinical red flag. The urgent care clinician has to immediately ask, was the cause clear and demonstrably reversible? Imagine this scenario. A patient who uses an insulin pump has a confirmed severe low because a pump infusion set failed, leading to a massive overdelivery of insulin. Okay, the patient is stable, the cause is corrected, and they have reliable home support. Clinical judgment often allows for a discharge with an intense education and follow-up plan. You avoid an unnecessary hospitalization and cost because the intrinsic risk profile of that patient is low.
The DOT's immediate, functionally prohibited ruling, while safe on paper, doesn't allow for that distinction. And here's my core challenge to your framework. Doesn't the rigidity of that DOT standard incentivize drivers to actively conceal or misrepresent episodes of mild or even severe hypoglycemia for fear of immediate job loss? If the standard is so unforgiving, it might actually push dangerous behavior underground and ultimately increase the risk of an unmonitored severe episode.
That is a legitimate concern about disclosure, but the DOT framework is designed to function despite that incentive. It focuses on the potential outcome, not the specific root cause. The fact is, if the driver's counter-regulatory mechanism failed to the point of needing external help, the system failed. Period. Regardless of whether the trigger was a missed meal, a bad injection site, or some systemic health change, the failure of that mechanism elevates the risk profile too high for operating a CMV. The regulatory liability risk for the examiner is immense if they certify a driver with a recent history of requiring assistance. The clinical setting can afford that nuance. The public safety setting simply cannot. The standard is designed to weed out functional unpredictability. We have to rely on the driver's ability to recognize symptoms and take action. If they fail that test, the regulatory system must enforce a period of demonstrated rehabilitation.
That rigorous documentation is really the bedrock of the standard.
A1C. The DOT's choice to treat A1C as context only, not as a hard pass-fail criterion, is a necessary nod to the complex clinical reality, but it doesn't go nearly far enough. We know the risk of acute lows operates on a U-shaped curve. Both a very low A1C, often below 6% from extremely tight control, and a very high A1C, say 10 to 12% or higher, both increase the immediate risk of hypoglycemia. The clinical framework recognizes that a low A1C often risks aggressive therapeutic overshooting and can mask dangerous nocturnal hypoglycemia. More importantly, modern clinical practice has moved way beyond A1C as the sole marker of control. We now prioritize metrics like time in range, or TIR, that we get from continuous glucose monitoring data. TIR gives us a highly granular look at glucose variability, the true predictor of instability, in a way that a single A1C number, which is just an average, completely fails to capture. If the DOT is so focused on predictability, why does it ignore the most predictive modern data we have available?
That's an interesting point regarding technology integration, though I would frame the DOT's position on A1C differently. The reason the FMCSA ignores A1C as a hard cutoff is precisely because the history of severe hypoglycemia and awareness are considered the only factors that truly predict sudden, catastrophic incapacitation. In that very specific context, A1C is secondary to a documented functional failure. However, that doesn't mean A1C is irrelevant. A high A1C, say 10 to 12%, is dangerous not just because of long-term complications, but because it is a proxy for chronic extreme glucose variability and, critically, impaired counterregulation. That chronic exposure to high glucose, it desensitizes the adrenal system. So this means that when the glucose inevitably drops, the body fails to release the necessary hormones, like adrenaline or glucagon, to stop the fall, which is the physiological mechanism that leads directly to unawareness and the risk of those sudden catastrophic lows. So the DOT focuses on the functional outcome, unawareness, but the underlying instability you're describing is exactly what we are trying to exclude.
But the clinical framework leverages that physiological understanding to intervene more effectively. When an urgent care clinician sees a high A1C, it isn't just a number. It immediately flags the need to assess for contributing comorbidities. For example, diabetic nephropathy, kidney damage. It significantly slows the clearance of insulin, which dramatically increases the chance of unexpected, delayed, and severe lows. We use that A1C instability to trigger a deeper dive into renal function and the therapeutic regimen, which gives us a much better method for flagging high recurrence risk than merely checking for an episode in the past 3 months. The DOT view, focusing only on the outcome of unawareness, is too blunt to address the root, modifiable mechanisms of the risk. And ignoring the modern data from CGM, particularly time and range, is a significant regulatory failing if the goal is truly safety. A driver with an A1C of 6.5 who spends 40% of their day below target is objectively far more dangerous than a driver with an A1C of 7.5 who maintains 90% TIR. Yet the DOT system, by focusing only on the past history of assistance required, misses this critical real-time stability assessment.
And challenge there is scalability and standardization. The DOT examiner, who is often a busy practitioner performing a functional exam, must adhere to a strict regulatory framework that can be uniformly applied and, legally defended. While CGM and TIR are invaluable clinical tools, incorporating them into a mandated national safety standard that has to withstand legal challenge. That requires a level of regulatory flexibility that the FMCSA has historically been very slow to adopt. The strictness exists partly because of the need for unambiguous, defensible standards in high-stakes public safety. And let's discuss the critical difference in the liability mandate here. Liability for the DOT examiner is focused intensely on showing clear, defensible reasoning that the driver is safe to operate a CMV under the regulations. Their liability is administrative and public-facing. The only path to lowering that liability risk is guaranteeing absolutely proper documentation using the specific forms required, and when there is any uncertainty about functional predictability, to err on the side of public caution. And that mandates non-certification or using the shortest possible certification intervals. This mandate dictates strict adherence to the rules about unawareness in severe episodes.
The liability considerations in the urgent care clinic, while just as rigorous, serve a different master. Lower liability risk is achieved through meticulous documentation of the standard of care, which involves shared decision-making and establishing a robust, executable follow-up plan. This process forces the clinician to look beyond the immediate patient presentation and assess external support structures. Does the patient have reliable home support to monitor them overnight? Do they live alone? What is their access to timely follow-up care? The documentation of that shared decision-making, which includes educating the patient on recurrence risk and the steps they have to take, is a powerful liability shield because it demonstrates partnership and due diligence. These factors support structure and collaboration are absolutely critical to individual safety and reducing recurrence risk, but they are marginalized in the DOT's primary focus on public safety disqualification. The clinical model inherently demands a supportive, collaborative approach that the DOT system, by its punitive nature, often undermines.
I think the clinical system relies very heavily on the patient's willingness and ability to comply with that follow-up plan, right? The DOT system, however, it cannot rely on the cooperation of family members or the patient's commitment to scheduling appointments. It must rely only on the objective, documented, functional ability of the driver themselves. The regulatory mandate means that if the driver has demonstrated a catastrophic functional failure, regardless of how reversible the underlying cause was. They have to be removed from the public road until they can objectively prove months of stability. That is a fundamental philosophical gap between our two frameworks. So to summarize my perspective, the DOT framework defined by these specific regulations is really an engineering solution designed to filter out functional unpredictability. Its rigor regarding hypoglycemia unawareness and severe episodes is essential because the cost of failure measured in public catastrophe is just unacceptable. By focusing strictly on objective history of failure, stability, and awareness, the DOT ultimately provides the most credible, legally defensible standard for a CMV operation, even if it requires overly restrictive measures in individual, isolated cases. It has to prioritize the safety of the population over the convenience of the individual.
I'm just not convinced that the DOT's strict functional view is the most complete or even the most effective safety measure, particularly, like I said, when it incentivizes non-disclosure. While public safety must undeniably be ensured, the clinical model offers a necessary and, I think, a deeper perspective. It recognizes that risk is a complex function of severity, clarity of cause, critical comorbidities like cardiac or renal disease, and the individual's support structure. This integrated approach handles the full double-edged sword of diabetes management. It balances the immediate risk of hypoglycemia with the long-term management of complications that will ultimately lead to the very functional decline the DOT is trying to prevent. A truly comprehensive standard has to eventually integrate advanced data like time and range to assess stability, rather than relying solely on the punitive metric of past functional failure.
We have thoroughly examined how these two different regulatory and clinical spheres approach the same underlying complex physiological risk.
Yeah, and it's clear that while their mandates diverge, one focusing on minimizing public catastrophe, the other on maximizing individual health and safety through an individualized assessment, both systems require extraordinary expertise and, nuanced judgment to navigate the complex, often contradictory risk profile presented by diabetes management.
There is much more to explore in how these dual standards impact real-world outcomes, particularly the ethical and practical conflicts they create for the medical examiner who's caught between their clinical oath and their regulatory duty.